I'm Digna Velez Edwards from Vanderbilt, and I will be giving you Project One updates for Visum. For Project One, Aim One, we're assessing the knowledge and attitudes regarding pharmacogenetic testing in a population of pregnant women and children with chronic conditions. For the study, we're recruiting 250 pregnant individuals and 250 children. These participants are administered a survey assessing their knowledge and attitude regarding PGX testing, followed by being administered PGX testing. The participants are then randomized into those that receive an educational video and those who do not receive this video or receive it at a delayed time. And then they're administered a follow-up survey that assesses whether there's been any change in their attitudes or knowledge regarding PGX testing. We've previously published a summary of our community engagement studio that we performed here at Vanderbilt in 2022. For this community engagement studio, we had convened participants from the Nashville area who met our study participant characteristics, and we got their feedback regarding our survey materials, as well as our recruitment approach and our recruitment materials. And this is published in Clinical Pharmacology and Therapeutics. You can see it here at this PMID. Currently, we have consented 541 participants for our pregnant cohort. 437 of those have completed baseline survey, and 261 have completed PGX testing. For our pediatric population, we have consented 450. We have baseline survey data completed on 325, and we have PGX testing completed on 190. We're done with recruitment for our pregnant cohort, and our pediatric cohort recruitment is still ongoing. We anticipate it being completed within the next couple of months. This study is going to be analyzed, or is being analyzed, by Elizabeth Jasper, who's leading the analysis of our baseline survey data and our trial data with regards to the effectiveness of our video for the study. And Alexandra Sunderman, who is doing the analysis of our initial recruitment population for our protocol paper. For the analysis of the pregnant cohort, we're looking at whether participant characteristics impact knowledge and attitudes, comparing baseline PGX survey with the participant characteristics. We're also looking at whether PGX testing impacts knowledge and attitudes by comparing baseline survey information versus post-PGX testing survey information. So whether their responses change after doing the PGX testing. We're also looking at, as part of the primary trial analysis, whether the educational video improves knowledge and attitudes regarding pharmacogenetic testing by comparing our survey responses before and after receiving the educational video. And then finally, to refine our recruitment approach and to better understand why participants move forward in our study. We're also doing an analysis comparing those who consented and completed our baseline survey but did not complete PGX testing to see if there's any participant characteristics that associate with those differences. Here's a summary of the participant characteristics for our pregnant cohort. This isn't all inclusive, just a brief summary of some key characteristics. Median age was 30 years of age, interquartile range of 26 to 34. 80.7% of the participants identified as non-Hispanic white, so approximately 19.3% were other racial ethnic groups. 52.2% had a bachelor's degree or greater. Over 80% of the participants were self-described as good or very good health. 67.5% of the participants reported taking at least one medication daily, and 44.4% of the participants reported experiencing an adverse side effect at some point in their life. So it was a population of individuals who had pretty good interaction with the healthcare system and in taking prescribed medications. As I mentioned, we had 437 who were enrolled and randomized into the study, and 261 actually followed up with the PGX testing, or 59.7%. We wanted to compare the demographics among individuals who did and didn't complete PGX testing in case there was any specific participant feature that associated with these differences. What we observed was that participants who followed through the study tended to be older, had higher educational attainment, were from higher income households, or reported taking a medication regularly. And these were the ones that were more likely to have followed up with the step of getting their PGX testing. Participants who were self-reported as Hispanic and had public insurance were less likely to follow up with PGX testing, what we observed in this study. This is a summary of our pregnancy cohort participants and their reported responses regarding their familiarity with key pharmacogenetic terminology in the baseline survey. These bar charts are color-coded from dark red is not familiar at all, and dark blue is extremely familiar. And on the y-axis is the specific terminology we asked them about. We observed that they were most familiar with basic terms like DNA, chromosome, and genes, but fewer, less than 50, reported familiarity with more complex terminology, including pharmacogenetics, metabolizer status, and precision medicine, which are terminology often included in testing reports for PGX results. When we looked at the responses with regards to the attitudes about the utility of pharmacogenetic testing in the pregnancy cohort, we observed that most participants believed that genes contributed to how individuals responded to medication. So this was 90% agreed. But greater than 90% also agreed or strongly agreed that PGX testing would help them and their doctor make decisions about their treatments. Most participants also agreed or strongly agreed that PGX testing would lessen the likelihood of side effects, so this was 67.3%, help doctors decide which medications are best, so 86.2%, determine the best or safest dose for their medication, so this was 85.3%, as well as enhance understanding of why they or family members do not or do tolerate responses to certain medications. So 84.8%. And across all of the responses, surprisingly, despite having very favorable agreement with regards to the prior answers I mentioned, only 45.6% thought that PGX testing would be routinely performed. This could be for many reasons, but despite having a very favorable perspective on the utility of PGX testing, few thought that it should be routine. Right now, we have drafted manuscripts for the maternal population that we plan to submit all of them by this summer for a vice imprint, their study design protocol analysis that we have drafted and are submitting it within the week. This also includes the analysis comparing why participants might have consented but didn't follow through with PGX testing. We have a manuscript on the association of participant demographics and baseline survey responses that we will submit in June. We also have the main manuscript for this, which is the effectiveness of PGX testing and the educational video at influencing attitudes and knowledge of genetic testing among pregnant individuals that we will submit targeting with June and July. For a pediatric population, as I mentioned, we're finalizing recruitment for the summer of 2025, and we will finalize all manuscripts this fall and doing mirrored analyses as we've done for the maternal population. For our second aim for Project One, we are validating drug-gene interactions in children and pregnant individuals. This is being led by Megan Shuey and previously by Vivian Kawai, who recently changed institutions. And for this, we're evaluating CPIC level A and AB drugs We initially started with CYP2D6 substrates. We published 2 papers in our pediatric population for propafenone and ondansetron. Currently, we have processed 590 samples from participants for propranolol using a twist panel custom array that includes multiple pharmacogenetic variants, including CYP2D6. And we're conducting that analysis now. For our pregnant population, we have completed a manuscript that we're in final stages to submit, also in May. On ondansetron, we had 311 eligible participants from 590 charts reviewed. And this is a completed manuscript. We're doing the final edits to it. We're also assessing antidepressant use, as well as G6PD and hemolytic events potentially. And this is just a summary of some of our published work on the right side of the page. For propranolol, we had initially identified 1,184 individuals with propranolol mention and biological sample available in our database called the synthetic derivative. Our inclusion criteria included at least 1 oral administration of propranolol, adequate clinical documentation to assess for adverse events, being less than 18 years of age at the time of first propranolol use, and any indication of propranolol use. We excluded IV or topical propranolol, and no administration of medication or only drug mention in chart. For propranolol, we're looking at adverse events that are cardiac and systemic. It includes these lists here that I won't read off. Adverse events included if they occur within 1 year of drug initiation. Adverse events were documented through manual chart review. Preliminary chart review shows the adverse event rate of approximately 22.9%, where 78% were systemic adverse events and 22% were cardiac adverse events in the 594 included participants. CYP2D6 activity scores will be assigned using CPIC guidelines, and statistical analysis will focus on association between activity score and presence of adverse events and time of adverse events. So we anticipate completing this manuscript in the 3rd quarter of the year. So by or late summer, early fall, we anticipate having this wrapped up, since we're in the middle of analysis now, and we had an outline draft already prepared for this. And that's the end of summary for project 1.